How's everybody doing? It's Dr. Gillard again. Let's do another dermatology lecture, shall we? It is week 8. It is spring 2020, and here we go. Interesting subject today. Now, we're going to talk about some nail diseases, and I've learned over the past that you don't know much about the nail, so let's go through a little anatomy of the nail. So the nail and its associated structures like the bed, the nail bed underneath, and the hard part of your nail, and the part that just touches your nail, that's all that stuff, including the stuff underneath the matrix. That's called the nail apparatus or the nail unit. The job of the nail, and when I say nail, I'm meaning really that hard plate. That's called the nail plate. The job of the nail plate, and really the nail apparatus, because the nail plate has to keep the cells that make up the nail plate, they need to be replaced. But the job of the nail apparatus is to protect the delicate phalanges underneath, the distal phalanges underneath. Okay, it also contributes to some motor and sensory function. I mean, if you very gently touch the back of your nail, there is a sensory function. You can feel to it. So there's some sensory components. Although it's really from pressure, you're pushing down on the nail. There's no nerve fiber or blood vessels, of course, in the nail plate itself. It's made just very similar to the skin, only remember the skin cells called keratinocytes are born down in the stratum basale. Right? So here's the skin, there's the stratum basale, here's the surface of the skin up here. The skin cells are born here and born again, and there's basal cells, which are stem cells, and they get conveyor belted upward, and then they slough off after about 25, 30 days or so. But that's not the way it works in the nail plate. So here's your fingernail, your nail plate. Right, there's your finger underneath. The cells, let's actually make them a different color. The cells are created by stem cells in the matrix, and there's two matrices we'll look at. But the matrix cells divide via mitosis, and a new stem cell is created. We don't call these keratinocytes. These are called onychocytes. Onychocytes. Okay, onychocytes, and they're pushed forward. This would be up here. I guess I could draw them up here, but they're pushed forward. Well, these are the deeper ones, so there's a deep matrix we'll go into, but they're conveyor belted forward like this. Okay, so it's just the opposite. The skin cells are conveyor belted as they're born upwards toward the surface of the skin. These are projected down the plane of the fingers, so it's a weird kind of a setup here. Another example of why I don't draw on the board. All right, so we said they're made up of tightly packed corneocyte-like cells, which are called onycho cells, or onychocytes. Keratinocytes are for the skin. Onychocytes are for the nails. Interestingly, there's no other animals in the animal kingdom that has, or fish or anywhere else that has nails. The only two creatures that have a nail plate are the primates, chimpanzees and gorillas, orangutans and that family, and the humans. The visible part of the hard outside of the nail is called the nail plate, which is, we're looking at this gorilla, has a nail plate right there. And the proximal nail plate, which way is proximal nail plate? Here? No, proximal nail plate is back here. So the proximal nail plate rests over the distal part of the matrix. Okay, the proximal part of the matrix is underneath this fold of skin we'll look at here in a second. And if you look down at your nails right now, you see most of you, not all of you, but most of you will see a white little moon-shaped thing, a crescent. You see it? So that is where the matrix is, but that's the distal portion of the matrix is underneath there. So sometimes we can actually see that tissue because it's very white looking. The proximal portion of the matrix is underneath that proximal fold, that fold of skin, which is really sensitive if you poke around on it. Right? If you get a, let's see, the distal part and the majority of the nail plate rests on a structure. If you pull off your nail, you have a bed of tissue underneath there, and that's called the nail bed. So the nail plate sits on the nail bed. I'll show you a picture here in a second. The distal nail matrix and the nail bed support the nail plate. Most of the proximal nail matrix is covered by the proximal nail fold. Take a look at a picture here. So make sure you know these terms so you won't understand what I'm talking about. I assume you know these already. So the hyponychium, which really isn't that clinically important, but if you stuck like a toothpick underneath your fingernail, that's the hyponychium. It's just underneath that distalmost portion where you can't separate your fingers, your skin or your finger from the nail plate. That's the hyponychium. There's lateral folds here, and then the proximal fold is important. It's this tissue right here. Right, this is the proximal fold. Okay, underneath the proximal fold is where the proximal part of the nail matrix lives. So if you dig down, and matrix is stem cells, right? That's where all these stem cells are located. And melanocytes live in the matrix cells as well, which we'll look at. And now you can see the lanula right here. And what is that created by? That's the distal portion of the nail matrix. So there's a stem cells underneath there. And they actually give rise to some of these onychocytes. All right. The cuticle, don't get that confused. The cuticle is in front of the proximal fold. So it's this little tissue. I'm going to block it out right now. But it's that little tissue right there. When you get your nails done, they try to take that tissue out, and it's actually really important because it stops bugs from trying to crawl up underneath your skin. So it's a good idea to leave it there and not smash it up like my wife has her nails done, and her nails are already sore. I'm like, what happened to your nails? Oh, they pushed that cuticle up. I'm like, why do you do that? Because they're ugly if I don't do that. Ridiculous. Leave it there. Okay, so I got all the parts there. The nail plate, of course. The nail bed we can't see. I don't have a warning, but I think this is a gross picture. Nope, not yet. There's a gross one coming, though. We're going to pull the nail plate off and somebody else just to see the nail bed. But here's a better, nice view here. You can see the nail plate on the top here. We'll make it a little thicker. Underneath it is the nail bed. And then the nail matrix is here. That's the proximal. That's the distal nail matrix. Here's the proximal fold. All of this tissue right here. And underneath the proximal nail fold is the proximal nail matrix, filled with stem cells and melanocytes as well. Oh, here's the gross picture. Sorry. I can't see the slides coming, so I can't warn you. But here's the case. You can see there's a brown lesion right here they're worried about. They had a Hutchinson sign, which we're going to look at. And they did biopsies and turned off to be cancerous, so they need to take it out. And they had to remove the nail plate to do this. And they pulled this up, and you can see it ripped part of the matrix right up. So this is the distal matrix right here, distal nail matrix. So these are cells that actually help give rise to the nail plate itself. What produces the nail plate? Cells from the proximal and distal matrix. We've already talked about that. Nail plate is a double structure. You don't know that. And they're stuck together. So kind of like the fibrous pericardium and the parietal layer of the serous pericardium are stuck together. Can't get them apart. Same deal here. But technically, histologically, it's a double layer. The proximal part of the matrix, which is under that lanula, that produces the dorsal surface of the nail, about the 1/3 of the nail. So the part you're touching, if you touch your nail right now, That's the dorsal surface of the nail. That's made by the cells under the lanula. The distal matrix, which is under the proximal fold, that produces about 2/3 of the thickness of the nail plate. And so that is an important one. If either one of these get destroyed, it's not a great thing. If you have a Hutchinson sign and they suspect a subungual melanoma and they have to do a biopsy, a big biopsy of the underneath the nail fold to see what that tissue is, it'll kill the proximal matrix. It may come back, it may not come back, but you still have the distal matrix underneath the lanula working, so you'll still have a nail plate to cover your finger. It may look kind of thin and a little wavy looking and a little gross looking, but you'll still have some protection there. You have to lose both matrices in order to not have a nail anymore, which does happen in some trauma. All right, here's a really nice little cartoon just showing us the distal matrix. Now, what I don't like about it is the distal matrix is only about this far. Doesn't go back this far as they're showing, maybe that far. And then this would all be the proximal nail matrix. So they kind of screwed that up. But it shows nicely, let me get that out of there now. It shows nicely the theory of, or the concept that your nail plate is actually it's a double layered plate. And the superficial part come from the proximal matrix, and the distal matrix makes the plate. I think I screwed something up. When they do a biopsy here for a Hutchinson sign and disrupt that, you will lose that superficial layer, but the distal matrix will still produce the deep 2/3 layer. So you will still have a plate there, but you'll lose your superficial layer if they do a biopsy here. And remember, this is normally not this far. This distal matrix is right about here. Okay. Birth of the nail plate. Let's see. So anicocytic stem cells, which live inside the matrix, they're the ones that are continually dividing. So they're just like basal cells of the skin. So we'll just call them anicocytic stem cells, or stem cells in the matrix divide. We've kind of said this by mitosis, and they give rise to anicocytes. And just like I explained before, they are pushed forward in the plane of the finger, so they're not perpendicular to the plane of the fingers, which is keratinocytes in the skin. They are conveyor belted perpendicular to your forearm. They go up in that direction. These go out perpendicular, parallel to the plane of your finger, parallel to the plane of your finger. And as they are born, they are stuffed with keratin, but it's a little different keratin. The keratin in your skin is called a soft keratin. This is hard keratin. So it's a different type of keratin, like hoofs, and your hair, similar to your hair, is a hard type keratin. Nail plate, some fun facts. The nail plate grows about 1 to 3 millimeters per week. Toenails are a little slower, about 1 millimeter a week. Fingernails are 3 millimeters a week, so it's pretty fast. So if you rip off a nail, you don't damage the matrix, assuming. It'll take anywhere from 12 to 18 months for that nail to grow back, but it usually grows back as long as the matrix hasn't been destroyed. Okay, so yeah, it usually grows back 12 to 18 months. The nail growth slows as you get, if you have diabetes, you have poor circulation, the nail growth slows down. Same with age, as you get older, it slows down as well. Anicocytes versus keratinocytes. Just like keratinocytes, 85% of anicocytes, or brain's off today a little, I think. Unlike keratinocytes, 85% of anicocytes are made up of hard keratin. Right? So 85% of the anicocytes is made up of hard keratin. You could call that anicocytic keratin, is 85% hard and 15% soft keratin. The keratinocytes of the skin only produce soft keratin, as I said. Hard keratin makes onychocytes very hard. Keratinocytes, interesting fun fact here, keratinocyte fat content is about 10%, whereas the onychocyte fat content is only 2%, so they're very lean and very hard. They don't have that as much fat content in there. Strangely, this is weird. So the nail plate is 1,000 times more permeable to water than your skin is. So the chances of water being absorbed through your skin is less than that of through your nails. That's really counterintuitive, right? Because your nails are hard as a rock, but they actually are fairly porous. Let's see. So you can actually, the medicine that you put on your nails, there's from onychomycosis we'll look at next week. It can go through the nails pretty good because they're porous. Nail apparatus versus distal phalanges. So this is important too. So we said that the nails protect the distal phalange, but there's a problem. We're missing the entire subcutaneous layer. Remember, the skin has an epidermis, a dermis, and then a subcutaneous layer, which has all kinds of AKAs, right? Subcutis, hypodermis. There's a bunch of AKAs for, call it subcutaneous tissue, but it's completely gone. Therefore, if you get an infection of your nail, it's pretty darn easy for it to get into your bone and cause osteomyelitis. Again, it's not a good idea to be jamming that cuticle back up. I tell my wife, she doesn't listen to me, because you get an infection of your fingertips, you can get it, osteomyelitis, you can get it into the bone, that can get into the bloodstream, and you could get septicemia from that. So that's kind of a delicate area. On the other side of the coin, people with disease of the bone, inflammatory disease like psoriatic arthritis, right? What comes to you when I say psoriatic arthritis and radiographs? What's the first thing that comes to your mind? Pencil in a cup. Pencil in a cup. The point of this, though, is because there's no subcutaneous tissue, the disease, the inflammation can spread and affect the nails as well, in things like psoriatic arthritis and rheumatoid arthritis. This is classic psoriatic arthritis, where you get the link sausage-like fingers here. This is rare. We usually don't see it involving the metacarpal phalangeal joints. It's usually the link sausage fingers. Goes with psoriatic arthritis. Pencil in a cup is the classic sign of this. So psoriatic, I guess we're going down a rabbit hole. Psoriatic arthritis, destructive autoimmune attack of bone, and it loves to whittle the intermediate phalanges down to make them look like a triangle. But yet the distal phalanx or distal phalanges, it tends to fatten them out. So you get this pencil in a cup, kind of upside down. Well, I guess it depends which way you hang your fingers. But you get this classic pencil in a cup type deformity. What do you make of those nails? It's another classic sign of psoriasis, psoriatic arthritis. Patient may have psoriasis skin lesions as well. These all go together. But these pits right here, look at all these pits. So that's the classic pitting seen in the psoriatic arthritis nail. If you go underneath and x-ray these patients, they'll have destruction of the phalanges in various degrees, and maybe pencil in a cup type anomaly. But that's psoriatic arthritis. Another pencil in a cup type thing. Don't forget pencil in a cup. Do you know that already? If you don't know that, there you go. The dermis under the nail. So there is and here's another reason why infection can spread and diseases can spread from the nail into the bone or the bone into the nail. Not only is there no subcutis layer or subcutaneous layer, or no hypodermis, whichever AK you want to learn, but the dermis underneath the nail is not the greatest as well. It's thin as well. It still has blood vessels and nerves, of course. But the other weird thing is the dermis connects directly to the periosteum of the bone. So that's where you'd think there'd be some tissue, but when I say there's no hypodermis, there's no hypodermis. The dermis literally connects to the bone. And we can see, here's the nail bed, right there. There's the nail, or there's the dermis, has blood vessels and everything, and it connects right to the bone. There's no subcutaneous tissue. Yeah, you can see the skin here. So now we got a little makeshift subcutaneous layer starting. This layer right here. And we come out to here, it's completely gone. How about some fun facts? That's gross, isn't it? Why would someone grow their nails that long? I don't know, but we've seen that in the Guinness Book of World Records. I think this is the guy, the champion. He has one normal hand for doing things. I mean, this hand is basically, what can you do with your hand that has nails growing like that? So that's just gross. But nevertheless, there it is. If you don't cut the nails, they will grow and grow and grow and grow forever until you cut them. They're not like the stratum corneum, which those corneal sites will kind of slough off after 30 days. These things just keep growing. The nail bed is interesting. So right under the nail plate, the nail bed is actually, you can consider that like an epidermis type layer. So it's a really brief version of epidermis. I'm going to even make a note to 23. I can add that epidermis theory there. Yeah, so we can add that in there. So the nail bed is a double layer epidermis. It has a stratum basale where some stem cells are. The question, $64,000 question, are there melanocytes here? So we're not 100% sure of that. Because normal the stratum basale is filled with melanocytes, and the darker you are, the more those melanocytes inject the newly born keratinocytes. They inject them with melon, which turns your skin brown. And that's it. So the stratum basale are born. They create keratinocytes, and they move up into one layer, stratum spinosum, and they die. They don't slough off. They're just reabsorbed by the body. So really strange system, and the 30-day cycle still applies. Right, beneath the nail bed lies that dermis, which rests right on the periosteum of the distal phalanges. Again, no subcutaneous layer. Okay, so that's the review. I'll probably cut that out now that I made this video. I don't know. Let me know in the comments. Do you need that review, or are you good enough with that? But anyway, let's get into the pathology. So I don't think you know this. Melanonychia. And that is melanonychia. It's aka longitudinal melanonychia. We've probably seen this before. Oh, look at that cuticle too. You can see the cuticle. Does he get manicures? No way. He does not get manicures. But he's got a melanonychia, longitudinal melanonychia there. So we need to talk about that. Most of the time, no big deal. Sometimes this is what killed Bob Marley. So it can be melanoma, subungual melanoma, malignant melanoma of the toenail, of the distal phalanx. Let's work through it. AKA is longitudinal melanonychia, and it's diagnosed when a person has a streak, a longitudinal running streak of black to brown. Could be variegated, different colors, but usually it's solid. Like this one's pretty solid, right? So it's pretty solid looking. And it runs down the length of the nail plate. These streaks can be thin, they can be thick, they can be variegated, meaning multiple colors, which is not a good sign. Thick is not a good sign. They could take over the entire nail plate. Not a good sign. Typically caused by activation of the melanocytes. And I should have probably added, and I guess I'll kind of go through this here, but there's melanocytes in the matrix, both matrices, but they're usually turned off. So therefore, especially Caucasians, if you look at your nails, they have like a little pink color to them, which is the tissue underneath, right? We can do the capillary refill test and turn them white. That instance where they're white, that's the color of your real nail. So usually their melanocytes are typically off. If a group of melanocytes gets turned on, they can inject the onychocytes with melanin. And that group will be brown. And that's exactly what happens. But there's other causes as well. So it's not just activation. And we'll get into those. But yeah, here's the melanocyte stage. Remember our little octopus there? And this is the stratum basale. This is the skin. But it would also be in the matrix region, both the proximal and distal regions of the matrix, both proximal and distal matrices have these melanocytes, but they're turned off usually. So they're usually dormant. Now what about the nail bed? Because it is a modified epidermis and it has a stratum basale, does it have basal cells? And the answer is we don't know. Surprisingly, there's not much research on this. I just read a 2016 paper on it. And this, using the most modern techniques of the patients, some of the patients, about a third of the patients had no melanocytes in their nail bed at all. But some of them did have melanocytes there. Why do I care? Because melanocytes, if they mutate, can turn into melanoma. So I don't know the answer to that question. We don't know. It looks like they're kind of like the intertransverse ligaments or interforaminal ligaments. Some people have them, some people don't. It's probably the deal with those things. So if a group of these, as we said, as a group of these matrix melanocytes they wake up and they start doing their job, making melanin, they're going to inject the adjacent onychocytes, and those guys are going to be ratcheted down the plane, longitudinally down the nail, and it's going to make a brown streak. If you biopsy the nail, that black part, you're not going to find melanocytes in there. They're just onychocytes, but they happen to be pigmented, right? The stem cells way back in the melanocyte region where the stem cells are. That's where the melanocytes are doing their job. So it's got nothing to do with the nail plate. It's just the end result of them, those melanocytes, which have woken up. And there's other things, as I said, that can do this. So typically a little cluster of these melanocytes wake up, and the clinical finding on the nail is called longitudinal melanonychia. Got it? There's another example. Is that the same one? So yeah, cluster of melanocytes have woke up right here. And we'll look at all the possible. There's a whole bunch of reasons. Pregnancy, a whole bunch of reasons, these things. Trauma, manicures, nail biting. There's a whole bunch of things that can wake these up. But if they're woken up here, when the stem cells make the cells of the nail plate, they get injected with melanin. The onychocytes, they get injected with melanin, and they show it. These cells, these onychocytes, have melanin. These don't. Okay, because just remember the growth is going that way. Here's another one. This is more worrisome. When they get thick, bigger than 3 millimeters, half of a pencil size. Pencil size was 6 millimeters. That's our kind of worry spot for skin size macules. Half of that, anything 3 millimeters or bigger, these bands bigger than 3 millimeters, definitely worried that this is cancer. It's even affected the skin out here. And it actually is subungual melanoma. But sometimes you don't know until you do. Nevertheless, the clinical finding, you don't say this patient has subungual melanoma. No, they have melanonychia. You can't tell the difference. Melanonychia is just a description. It's like radicular pain. Just means the patient has pain going down the arm or leg in a band-shaped distribution. You do diagnosis, you find decreased reflexes, then you make the diagnosis of radiculopathy. Same deal here. He has melanonychia, but if you do a biopsy and you find dysplastic cells down here in the matrix, then he's got melanoma, subungual melanoma. Got it? Right? Here's just that little cartoon I already said. So whatever, maybe this person had some kind of trauma, or they had a manicure and they were too rough here, and for whatever reason, these melanocyte groups, they woke up and they started doing their thing to inject the anicocytes with melanin, and at day one, maybe they started with a little brown streak here, but the brown streak grew longer and longer and longer and longer as time went on. Okay? I think we got that now. What are the causes? You're not going to like this. What are the causes of melanonychia? Well, there's two big causes. You can break it down into functional melanocytic activation, which is just the melanocytes wake up. Something stimulates them to wake up. So that's called functional melanocytic activation. Functional melanonychia is another, aka matrix melanocytic activation is another one. And then the hyperplastic conditions, melanocytic hyperplasia. Hyperplasia, in this case, is not going to mean thickened cells. It's going to mean too many melanocytes. Too many. They may be cancerous. They may be dysplastic. They may not be. So if they're not dysplastic, which they usually aren't, they're benign. If they are dysplastic, you're in trouble. That's what killed Bob Marley, is this situation right here. Let's look at the functional melanonychia first. What creates this melanonychia? That's not dangerous at all, but it could indicate underlying disease. So there's many, many causes, and we said that the dormant matrix melanocytes woke up and they started injecting anicocytes with melanin. We said that a million times already. So let's look at the causes. I do like this slide. Pregnancy, temporary cause. Nail biting, manicure, so nail trauma of any kind. And your toenails can get these too, right? Wearing tight fitted shoes all the time can cause them. Some diseases. Our friend psoriasis again. Psoriatic arthritis. Usually the more severe type, which causes pus-filled lesions, called pustular psoriasis. Addison's disease we've studied extensively. HIV. People of color are really prone to these things, especially African Americans. We'll look at that in a minute. People undergoing cancer, chemotherapy agents. The radiation exposure from CT or X-ray can do it. And then fungus underneath the toenail can result. That's called onychomycosis. We'll look at next time. All right, what's the deal with people of color? Well, it's been known for a long time that the darker your skin pigmentation, the greater the chances you will have of having one or more nails with streaks in them. And African Americans are probably the best example, even though Indians, like American Indians, have the highest rate. Or no, they have the highest rate of melanoma, actually. So African Americans have the highest rate. They're the biggest affected. But Hispanics, Asians, any people with dark skin can be affected. African Americans get picked on in this category. Greater than 90% have had at least one activated group and one melanonychic nail in their lifetime. So very common in them. So here's one. A little scary. Looks like a Hutchinson sign starting, but these turned out to be just fine. Kind of idiopathic. That for whatever reason, the melanocytes woke up. And we got one going here. We got one starting right here. That's a little bit wide. They had to go get a biopsy, but it's okay. In a couple more weeks, this thing will be all the way out here. Okay, we'll look at the causes. Or we looked at the causes. Here's a faint one. Another African American, real faint. Not very worrisome usually. We'll go through the ABCs of this when you can worry. I think we've seen that picture before, but another picture. All right, so that was they just wake up, and that was the category of functional melanonychia. Okay, now melanocytic hyperplasia. This is the second category, and there's two subcategories underneath hyperplasia. And this time, melanocytes are not only turned on, but there are too many of them. They've bred, and we have little regions of way too many melanocytes, and they're turned on. They're not supposed to be too many of them. They're supposed to be evenly distributed in the matrices of the nails, and they're not supposed to be turned on. So here we have a clump of them, and they're all turned on. So they make all the onychocytes going outward are just highly pigmented. Okay, the key is when you get a biopsy, there'll be no dysplastic cells. There's no cancer cells, right? There's no mutated, immortal onychocytes growing or nothing like that, right? There's no dysplasia, right? There's two types of melanocytic hyperplasia: benign, which is benign, no big deal, and then there's the malignant. And these are the benign. These are the moles. You have moles all over your body. You can have moles in the matrix as well. So no big deal. But then there's the dreaded malignant melanocytic hyperplasia, aka subungual melanoma. So those are not good. So let's look at the benign melanocytic hyperplasia first. So there's two categories of this, the main categories, which means the cause of benign melanocytic hyperplasia. There's two causes. So lentigo, remember we talked about lentigo skin lesions? Very, very common solar lentigo. These lentiginines are super common in older people. And these are caused by exactly what I said already. Abundance, too many melanocytes are living in the matrix, and they're just living and overproducing melanin and over-injecting onychocytes. Therefore, you get these streaks. There's a brown streak. The key is that lentigo lesions are more spread out. The cells are not clustered into these nevi, these clusters, these type nevi of mature melanocytes and immature melanoblasts as well. Those are called nests. So there's no nest. In lentigo, there's no nest formation. Got it? Lentigo of the nail, which is a category of benign melanocytic hyperplasia, there are no nests of melanocytes. These are the ones most commonly seen in adults. They've been with you probably your whole life. Because they are active, they're producing melanin, they're injecting the onychocytes, and your onychocytes, as they stream forward, will be pigmented. And these are not. How come these are not pigmented? They're streaming forward. Because the melanocytes here are not active. They're sleeping like they're supposed to be. Why these woke up is a mystery. But they have woke up, and lentigo lesions are usually with you for life. All right? And the other type is a mole, a nevi or a nevus. Nevi is plural. Nevus is a mole. So this is like a mole in the matrices of your nail bed. And the mole, the melanocytes, they hang out in really tight packs called nests. Thousands of them can be in a nest, and they're all activated, and they're secreting too much melanin, and they're doing the same thing, though. They're injecting the onychocytes and making them go forward. The only difference between lentigo of the nail and nevi of the nail is the grouping of these things. In nevi, the melanocytes group into a nest. They pack into these huge communities, really tight packed. And lentigo, the melanocytes, there's just too many of them, but they're scattered in a bigger region. Okay? Lentigo, no nests. Nevi, nests. And so more common in children, much more common in children. What about malignant melanocytic hyperplasia? So I should put the 8K. Let me write that down to add to the slides. Before I do want to add. Subungual melanoma is malignant melanocytic hyperplasia, is an AKA for that. Some facts about it: they typically occur in the thumb or the great toe, or maybe the index finger, so they're like the big digits. Typically strike in older people in the 60s. 2% are Caucasian. 33% are Native Americans. Native Americans are susceptible to malignant melanoma of the nail, subungual melanoma. And then the other races of color, Latinos, African Americans, Japanese, Chinese, about 17% of these show up in that population. Okay. All right, so this is Habib's list, kind of the ABCDEF rule. When do you, because you're going to run into patients that go, oh, look, my kid, he's got this weird streak down his nail. Or look, I just have a streak starting in my nail. What the heck is that? Well, you can tell them it's melanonychia. But the question is, are you worried about it? So here's when you get worried. If they're between 40 and 60 years of age, one check. If they're African American, Hispanic, or Asian, another check. But Native American, I mean, that's the big one that should be checked. Let me make a note of that. These are brand new. I made some of these slides this morning, so. Always striving to improve your education. Let's say 42. Okay. So those are the A's. B's, black or brown in color. I mean, most of them are going to be black and brown. But the other B is breadth. So that's the width. If they're 3 millimeters or greater, then we have a problem. Then you get worried about it. Change. Has this come on in the last 6 months to a year? Have you had this all your life? It's probably you've had it all your life and nothing's changed and the skin hasn't changed color. It's probably no big deal. But if this has come on in the last 3 or 4 months and there's no reason for it, then you start getting worried. D, digits only. So do you have any more of these lesions popping up on your skin anywhere? Or are they only on your nails? E, extension. This is the big one. So Hutchinson sign, if the pigmentation extends into the proximal fold of your nail, that is not a good sign. That quite often indicates cancer. Subungual melanoma, not a good thing. And F for family history, if your parents, brothers, sisters, grandparents have had a subungual melanoma, not a good sign. So you get 3 or more checks on this thing, and you need to send them out. I mean, if some of these, if you have one check, send them out to the dermatologist. If it's widening, check, send them out to the dermatologist. Triple check. If it's got into the nail, the proximal fold, the skin right before the nail plate starts, got to see. I'm very worried about that one. That's called the Hutchinson sign, as we'll see. In fact, let's look at it right now. So Hutchinson sign is when you get a discoloration, not only in the nail, but see how the proximal nail fold is now affected. Okay, so that's not good. That's a Hutchinson sign, pretty strong indication of cancer. Sometimes you get a chunk of the nail, the cells here get brittle as well. Because now, what is going on with this? You still have melanin being injected into the leukocytes, just like all these conditions. But the difference is these melanin producers are cancerous. They're dysplastic and they're invading. And in fact, they're invading up and to the point where you can see them in the skin now. So that's cancer. They can get into the bloodstream and off to the races. Really bad one. Another subungual. Guy waited way too long. White guy. right? So that's a Hutchinson sign. That's a taken over his, filled with cancer, all back in here. They had to amputate his toe, and hopefully it didn't spread. Some other ones, really scary looking ones, right? Hutchinson sign, Hutchinson sign. A lot of nails are split in this too as well. Hutchinson sign right here. Some bad signs of Melanonychia. So signs, and again, I just put the A, B, C, D, E's in this morning. So this would just, I just left these in. These are the big signs, but Hutchinson sign, bad sign if that's there. If the width is greater than or equal to 3 millimeters, I need to change that one as well. 46. Greater than or equal to. Not good. Send out for a biopsy. If it's variegated, so Habib didn't use this one, but if it's variegated, multicolored, that's a bad sign as well. Should be sent out for biopsy immediately. And if there's a rapid increase in either in thickness, in breadth, or width, send them out. Here's a variegated one. You can barely see it here, but when you put a little oil on top of it, it brings out the colors. Not good. That turned out to be melanoma. Here's another one. Subungual melanoma. Another one. Variegated, way wider than 3 millimeters. That's 6 millimeters probably. Okay. I've completely lost track of time, but I have a feeling we're around 40 minutes, 45 minutes. So we'll save the longitudinal ridges and beading for next time. All right, see you in the next video.